Thank you very much, and it's great to be back in Canada presenting. And I've had an interesting few days leading up to coming to Banff. I gave some presentations in Edmonton, Saskatoon and Regina, so I've seen part of the country that I hadn't seen before. And it was interesting, I rang my son from Saskatoon and told him it was minus 12 degrees, and he said, "How far up the mountain are you?" And I said, "Thomas, no, there's no mountains around here." Just the contrast I think there is in Canada is incredible in terms of the landscape. Somewhat similar to Australia in some respects. I'm going to try and give you an overview of what's happened over the last sort of 12 months in Australia, and it has been a remarkable time in hepatitis C, clinical medicine and public health. These are my disclosures. I thought I'd start with a disclaimer though. So firstly, DAA access in Australia is not quite universal. You have to be 18 years of age to get access to DAA therapies, and there's obviously pockets of other people with chronic hep C that find access very difficult. Our experiences are very early, and our learnings may or may not have relevance for other settings. This is our cascade of care. We estimate around 230,000 people living with chronic hepatitis C, of whom just over 80% are diagnosed. So this is the end of 2015. So 2 decades of interferon-based therapy led to treatment of only just over 20% of the population, curing 14%. Modelling, looking at the advanced liver disease complications that were going to arise in Australia without improvements in treatment uptake and outcomes, showed that we were clearly on an exponential curve, as most countries have been on, with numbers progressing to decompensated cirrhosis and HCC looking quite alarming. So we're very fortunate that this is the point where the DA era has begun, and our first task in some senses is to really get that burden of advanced liver disease complications turning around. Lesson number 1, broad DAA access is achievable, particularly when large discounts are negotiated. So the key elements of the Australian hepatitis C strategy are that we haven't just sort of started putting all this together. We started national hepatitis C strategies back in 2000. We're in our 4th national hepatitis C strategy. And I think that came together somewhat modelled on the HIV response in terms of a partnership between government, community, clinical peak bodies and academic representatives. And one of the key meetings that was held to really lead to broad access to DAA therapy was the Pharmaceutical Benefits Advisory Committee, which is an independent body that advises the federal government on safety and efficacy and cost effectiveness of new therapies, held a stakeholder meeting. They brought together all these groups, and one of the pivotal aspects of that meeting was when they talked about high drug pricing and how we're going to come to terms with that in the context of wanting to treat large numbers of people. A lot of the clinicians really had the view that we did have to focus at the advanced liver disease to make sure that we provided access to that group and turn that burden of advanced liver disease complications around. But the community groups were absolutely in unison. They said, no way can we do that. No way can we prioritise treatment to people just with advanced disease. We need access to all. And the drug companies were in the room as well, and it was really interesting, I think, to have that discussion. And I think there were 2 options. You could either go for high drug pricing, small numbers of patients treated with a targeted approach, or you could obviously get the price right down and have a broad access program. So I think it was really important to get those groups together in terms of the discussion around the response. And those community groups, both on the drug user side and the hepatitis C side, have importantly been funded by federal and state governments for many years. And as I said, they really were a powerful voice. We've also had general practitioner addiction medicine clinician education on hepatitis C from the early 2000s. And I'll talk a bit later about the sort of broadening practitioner base, and I think that's been quite pivotal. A monograph on hepatitis C management was sent out to every general practitioner in the country in the early 2000s. We've obviously had a harm reduction approach, which has been pivotal on the prevention side for many years as well. And I think importantly, we've had bipartisan support and political leadership. So as was the case with the HIV response, I think there was a pragmatic public health approach from both major political parties to hepatitis C. And the government that brought in this broad access scheme is on the conservative side of the political spectrum, so it's not a left-leaning government. So this is our fourth national hepatitis C strategy. We're in the middle of that. And we also got together in late 2015 when we knew the therapies looked like they were going to be listed on the government subsidised program and developed consensus guidelines of management, which were released the day that they became available in March 2016. This is our health minister at the time, Susan Lee, and Australia, certainly not the only country that's made access to all public health policy, but one of the first countries. In March 2015, this independent advisory group, PBAC, recommended funding of these regimens across the disease spectrum, but importantly, they said that the cost effectiveness should not be $40,000 or $50,000 per sort of quality adjusted life year. They said the cost effectiveness should be $15,000 per ISA. So that sent a very clear message that if we're going to have broad access to these therapies, we need to get the price right down. In May, the Health Minister announced that access for all to these therapies was a priority, and it did take several months of sort of negotiation to get the deal done. But in December 2015, it was announced that $1 billion was being invested in hep C therapeutics. And I think importantly, that investment was over a 5-year period. So it wasn't a 1-year contract that was being developed by the federal government and the pharmaceutical industry, it was a 5-year contract. Some of the key features of the program, several regimens have been subsidised since March. So all the key regimens, we're hoping that sofosbuvir and velpatasvir will be listed on the program in April or May. Zapatir was listed in January. No restrictions based on liver disease stage or drug and alcohol use. No cap on the number of patients treated per year. So we can treat as many patients that can come forward. There is a cap on expenditure and a risk-sharing arrangement. So the companies are still getting a reasonably good return on investment. I mean, $1 billion is a lot of money. So they're guaranteed, in a sense, $250 or maybe up to $300 million a year. Importantly, the government has security in knowing what their budget impact is going to be going forward in terms of a maximum expenditure. And obviously patients are absolute winners in terms of access. A broad practitioner base, so it's not just gastroenterologists and ID specialists that can prescribe. Any registered medical practitioner can prescribe these therapies in Australia. When the program started, the non-gastro ID specialists and other clinicians needed to go through a loop of consultation with a specialist. So they would send clinical details of the case to a specialist, and I've lost count of the number that I've done, but hundreds of those approvals. So that would be sent through generally on a form by email, and you look through the clinical details and give approval to go ahead. That requirement for consultation has been dropped for the higher caseload general practitioners and other clinicians in November. So if you've treated more than 10 patients with DA therapy, you're considered a sort of relatively high caseload general practitioner. Retreatment, including for reinfections, is allowed. So if someone becomes reinfected, there's no problem in terms of getting an authority to prescribe again. And we can try and construct, obviously, a retreatment regimen for those with virological failure. A small co-payment for patients. If you have a pension card, you pay $7 a month. If you don't, $38 a month. Lesson number 2, initial DA treatment uptake has exceeded almost all predictions. At the end of 2015, in a meeting, they went around the room asking us how many people we thought we could treat in 2016. I said 25,000, and a lot of people laughed at me. So we've done better than that, and I'll show you the data shortly. But I think people have been incredibly surprised, but obviously encouraged by the numbers of people that have come forward for treatment. And I think the reasoning in terms of how low some of those expectations were is how few people we were treating in the interferon era. So these are our data on treatment with interferon-based therapy since the mid-1990s. And there was obviously some improvements, addition of ribavirin, then removal of liver biopsies, a mandatory pre-treatment requirement, and then pegylated interferon, addition of the first generation protease inhibitors but very small sort of increases in terms of numbers treated. So never getting beyond treating 1.5% to 2% of the chronic infection population per year. We started getting a little bit of interferon-free therapy through compassionate access programs in late 2014. That increased in some very generous programs by the pharmaceutical companies in 2015. So we did treat a relatively large number of people with cirrhosis in 2015. But this is what's happened in 2016. So it's preliminary data through to the end of December. We've got individual data up until the end of September. We've treated 26,000 till the end of September, and we're estimating somewhere between 30 and 33,000 for the 10 months of the program since March 2016. These are the regimens, and the regimens tell you a lot about the genotype distribution, obviously. So 57% sulfosphate-lidiposphere, that tells you the genotype 1 proportion. Sulfosphate-declatosphere, although listed for genotype 1 and genotype 3, is largely used for genotype 3. So that's very similar to the genotype distribution we have in Australia. Very little of the AbbVie regimen Vicirapac. It was only listed in May, and I think people are choosing, obviously, sulfosphate-lidiposphere. It's interesting, we get information on at least the planned treatment duration. We'll get further information about treatment completion shortly. But if you look at the planned treatment duration, it's interesting on a few fronts. So if you look at sulfosphate-lidiposphere, only 13% are being planned for 8 weeks. So there's some clinician conservatism there, clearly. We would anticipate about 30 to 35% of people should fit into the category of genotype 1 treatment naive pre-cirrhosis, less than 6 million viral load. But in the context where the treatment cost to the community is the same, whether it's 8, 12 or 24 weeks, I think clinicians are thinking, well, we might as well give 12 weeks. What's the downside with a regimen that's very well tolerated? The sulfosphate-declatosphere gives us a lot of information about the proportion of advanced disease patients we're treating. So the guidelines are genotype 3 cirrhosis, 24 weeks of sulfosphate-declatosphere. Pre-cirrhosis, 12 weeks. So that 38% in the sulfosphate-declatosphere prescriptions is a good way of telling us how many people with cirrhosis we're treating. There might be a little bit of conservatism in patients with F3 being treated with 24 weeks, but I think it's useful to try and then estimate the proportion of people with cirrhosis that we've already treated. So we've estimated the number of people living with hepatitis C cirrhosis in the country. That includes, obviously, people undiagnosed with cirrhosis. And putting together the early access programs and clinical trial numbers, we estimate around about 60% of people with hepatitis C cirrhosis have been treated already. So that's clearly important if one of our major aims is to turn around that rising burden of advanced liver disease complications. If you look at the age distribution of the treatments, you can see how it's changing. So those early months, March, April, May, clearly there was large sort of so-called warehouses in the bigger clinics, many patients with more advanced disease, and you can see the proportion of people less than 50 in March, for example, is only about 25%. But as the treatment was rolled out and broadened, that proportion now has increased to 50%. So clearly there was some targeting of people with longer duration infection, more advanced disease in those early months. Third lesson, so a broadened prescriber base is possible and should be the foundation for sustained DAA uptake. If you look at the monthly numbers, clearly it's a warehouse effect. So it's not surprising that we had very large numbers in those early months. But what's going to happen over the next sort of year will be incredibly interesting. I mean, there could be a continued decline in the number of treatment places or people coming forward, and that would be disappointing, and that would lead to possibly somewhere between 10 and 20,000 people being treated in 2017. I'm relatively confident that we will be able to treat somewhere between 25 and 30,000 patients in 2017. And the reason why I'm confident about that sort of number, that sustained 2,500 people being treated per month, is because of this broadened practitioner base. So if you look at the prescriber types in terms of people prescribing DAA therapy over the first several months of the program, you can see back in March, largely gastro-ID specialist DAA therapy. But as the program has moved forward, the proportion of general practitioners and other prescribers is increasing. So we got to a level in September where about 20% of treatment was through general practitioners and other prescribers, addiction medicine, clinicians, sexual health physicians, etc. So I think that will be crucial to maintaining the momentum and broadening the treatment access out beyond the larger specialist centres. Clearly there's a lot of work to be done. We need to raise community awareness and enhance screening. We still have that 20% of people to diagnose. I think curing around 30,000 people in the first year is a great community awareness program, because those people often talk about how easy it was to go through the DAA therapy and through their social networks and other networks. I think that message is really getting out. Clearly we need to continue GP education programs and mentorship, enhance drug and alcohol and prison-based hepatitis C treatment, optimise OST and NSP coverage. We should never forget about other prevention modalities, and access to retreatment for reinfection. And as I said, that is within the guidelines. And access to the new regimens as they come through, because we're treating so many people, we will have a large number of people who will require salvage therapy, and the current regimens that we're trying to construct are absolutely suboptimal in the context of second-line therapy. And importantly, monitoring and evaluation to see how things are going as we move forward. I think the fourth lesson is that a range of models of hepatitis C care and treatment are required in different settings. I just wanted to give a bit of a personal perspective. I am fortunate enough to work in 3 different clinic settings. So I work in a large sort of tertiary-based clinic, 2 ID docs and a gastrohepatologist at St Vincent's in Sydney, and 2 hepatitis nurses. I also work do a fortnightly clinic at a methadone clinic on the same campus. And this is just looking at the populations of people who inject drugs, just to give you an idea of the different needs, in a sense, for different populations. So 230,000 people living with chronic hep C, we estimate around about 80% of acquired infection through injecting. Within that group, about 45,000 are currently injecting, our estimates. Only a third of those are on OST. Then you have a proportion of people that are on OST not currently injecting. And that 45,000 people will clearly be crucial if we are going to move towards hepatitis C elimination. So these are just my numbers in terms of DA prescriptions over the first 10 months of the program. So, I mean, I'm a clinician that everyone knows has no problem treating active injecting drug users. Our clinic has never had an issue in terms of treating people that are actively injecting. But if you look at my numbers, only 16% of the people that I've treated since March last year are currently injecting. That's probably higher than a lot of clinicians and a lot of clinics, larger clinics around the country, but it's certainly not enough to get to those very large marginalised populations in terms of access to care. But I've also been fortunate to do a monthly clinic at Kirkton Road Centre, a community health clinic that was set up in the mid-80s in response to the HIV epidemic that targets at-risk youth, sex workers and people who inject drugs. And I've mentored and trained up a team, a sexual health physician and a hepatitis nurse that are doing great work in terms of the treatment there. So since March, this was the first sort of 6 months of the program there. They're up to about 130 of their regular clients that have been on DA therapy. And you can see that 75% of people in that clinic setting are current injectors. And most of those current injectors, in fact, are not on OST. So I think this makes the point that we really do need different models of care and different access points. I had a debate a year or so ago with someone about hepatitis C elimination, and he said, well, we just need the current injectors to come to my office and get treatment. Well, that's not going to happen. It's not going to happen in enough cases to really provide broad access to marginalised populations. So we absolutely need a range of models of care. What has been sort of uniform across these settings is how grateful people have been that the government has provided this access in terms of DA therapy and the relatively rapid sort of uptake. Incredible adherence. Even at the Kirkton Road Centre, the adherence has been very good. And at Kirkton Road a program of individualisation of therapy delivery. So we don't there insist on directly observed therapy. There's a small minority of people that come in every day, largely people that are coming in for their methadone to the community health clinic and are given DOT. Another proportion of people come in weekly, and another proportion of people coming in monthly. So the sort of adherence package, so to speak, is discussed with the client, and I think it's a really good demonstration of the need to sort of individualise that adherence monitoring and delivery. Look, elimination's a tough task. Even achieving WHO HCV elimination goals will be difficult, but certainly worth striving for. We're doing a range of work looking at trying to provide further evidence around treatment as prevention to form the basis for elimination. We have a large project, Stop C, in the prison setting, where we've been monitoring incidents of infection for the last 2 years. We're about to rapidly scale up with sofosbuvir velpatasvir in a network of 4 prisons, and then monitor the impact that that has on transmission within the prison setting. During the surveillance phase, people have had standard of care access to treatment in the prison setting, although the numbers treated are not incredibly large. We also have a major national initiative, CEASE, to eliminate hepatitis C in the HIV population, and a range of other studies looking at populations of people who inject drug studies. So I think it's a really crucial time that we start to gather empirical data. Our modelling tells us that elimination is feasible, but mathematical modelling is only part of, obviously, the evidence in terms of elimination. We really do need to start to move towards empirical data. Monitoring and evaluation will be important. We're monitoring the uptake. Some of the data that I showed you will continue to do that. We've set up a national registry of real-world outcomes to look at outcomes across clinics, both tertiary care, primary care, drug and alcohol, and prison setting-based clinics. We're looking at the impact on liver disease burden. So we have a very large project in New South Wales where we linked more than 100,000 Hep C notifications with a whole range of administrative data sets. So we're monitoring the numbers of HCC cases, we're monitoring decompensated cirrhosis through hospitalisation, admissions, and we'll be able to then also get data specifically on the individual treatment through what's called the pharmaceutical benefits scheme. So it'll be a very powerful sort of data set to look at the population level impact. We also have an annual survey of around 2,500 people who inject drugs through NSP sites, and we do finger prick dried blood spot collection. We've been testing for HIV and hepatitis C antibody for 2 decades. We've added in Hep C RNA evaluation last year, so we'll be able to monitor the viremic prevalence among the active injectors going forward to see how we're doing in terms of treating that population. We're also doing sequencing for resistance to look to see whether that will emerge as a significant problem. And we're asking about whether people have been treated over the last sort of 12 months. So we'll have a lot of really valuable data through that mechanism. Our notification system's pretty good, so we'll be monitoring the younger age notifications to see whether that's trending down as a marker of potential population level treatments prevention effect. We've launched a national campaign. A famous Australian artist, Reg Mombassa, put his hand to developing some artwork for posters and T-shirts, and so we launched this in the middle of last year. So it's been a great sort of time to get people together and start to think about the possibility of elimination. I'll leave the final words to Graham Foster, who's a leading hepatologist from London, who came out last year and gave us a talk. And he obviously was amazed at the opportunity that we had in Australia in terms of the broad DAA access. His final words were, though, don't stuff it up. But I think the reason he said that, he said, if you can help provide evidence of population level impact with a broad access program, that will be very powerful in terms of advocacy for other governments to invest in hepatitis C around the world. And finally, I'd just obviously like to thank a large number of people, both internally at the Kirby Institute in Sydney and our national and international collaborators and our funders, both public and private. Thank you very much.
questions?
Are we having questions or the
Yeah.
panel discussion? How's that going to work, Jason? Yeah.
Well,
We'll start the panel, and then we can ask questions. Unless you have a burning question. Sure. And maybe the panel they know who they are, if they can start.
So my question is, in your statistics, data collection, do you collect statistics on Indigenous people? And if you do, what is the percentage, please?
Yeah. So the Indigenous population in Australia clearly have a higher risk of hepatitis C. The notification data shows that the rate of hepatitis C diagnosis and notification is about 6 to 7-fold higher amongst the Indigenous population. Our Indigenous population in Australia is about 2.5% to 3% of the total population. So the Indigenous population make up somewhere between 15 to 20% of the hepatitis C population. So clearly it's a crucial population. We're developing Indigenous-specific strategies to try and provide broadened sort of access to Indigenous populations. We have a research program where we're going into Indigenous communities, doing what's called a Live a Life type project that we've adapted for Indigenous communities, working with the communities themselves in terms of enhancing screening, linkage to care and treatment, and we'll be looking specifically at outcomes in that program. So there's a lot of, there's definitely a lot of people that are working hard to try and provide that access. And part of the monitoring and evaluation will be to look at what the uptake is across the country in different subpopulations, and to make sure that we are sort of reaching populations in a relatively equitable fashion.
I have a question, but first I want to make a nasty editorial comment, and it's not addressed to anyone in this room, but we've just gone through this drug pricing process in Canada. It's called the Pan-Canadian Pricing Alliance, and I just absolutely hate that it's completely shrouded in utter total secrecy, total lack of transparency. Not only do we not know the eventual drug pricing or any parameters thereof, but we have which is expected, but we have no clue to the, how the process worked, who's on the committee, how decisions were made. It's so bloody frustrating and annoying. Anyway, sorry, I stop before I give myself a blow, an aneurysm or something. My question is, the congratulations on that fantastic achievement in Australia. Do you have any kind of idea was there an approximate range of cost per patient that they negotiated?
Yeah. So I think, Sam, the first aspect to that is that I think the negotiation process I'll simplify it right down. I think the government was happy to invest $1 billion, and that's not an insignificant amount of money. And I think the discussion with the pharmaceutical industry was, as I sort of said, okay, we can spend $1 billion or a bit more and treat, say, 20 to 30,000 people with relatively advanced disease at a price of $50,000. Or we could treat maybe 100,000 people at a price of $10,000 per course. I'm not saying that that's the price, or the price is confidential. But we know that the investment is $1 billion. It might be somewhere between $1 billion and $1.5 billion. We know that there's no cap on treatment numbers. We know that it's an annual sort of cap on expenditure. So I estimate that probably in 2016, the government spent $250 to $300 million to treat 30,000 patients. So you don't need to know the exact details of the arrangement to know that that's a pretty good deal. We've sort of sent in a letter to J Hepatology in response to a paper from Germany that talked about their program. In 2015 in Germany, it looks like they spent €1.2 billion to treat 20,000 patients. So you do the math, and we don't know all the details about rebates and insurance, but it sounds like they spent over €1 billion. It looks like Australia's getting a deal that's maybe somewhere towards a tenfold reduction on the price. So that sort of disparity is just crazy. It's absolutely crazy. And something needs to be done about it. I think it is being done about it. I mean, Italy I think the Italian health minister a couple of weeks ago said, we've been spending €40,000 per course, we can't do this anymore. We're going to spend €4,000 per course. So if we're going to even have a chance of heading towards elimination in many countries around the world, this needs to be addressed. And look, I'm just grateful that people did come to the table at the right time in Australia to get this deal done. I think we were lucky that we came at it a little bit later. So the PBAC actually knocked back soft RIBA submission. So we had another sort of 9 months or so, and I think by then things had changed a little bit in terms of the dynamic and some of the pricing. So I think we were very fortunate that we had that sort of window of opportunity.
Carla Coffin, University of Calgary. In terms of your experience with expanding the care provider network, like what was their feedback? You know, I've treated 10 patients, now I feel comfortable. Like it's so highly specialized now in Canada, like even GI are not comfortable treating many hepatitis C patients. And maybe for the rest of the panel, like Jordan and Mel, like what do you think we should do to try and roll out care in Canada?
Yeah. So just to address it first, I think one thing to say is that we've had a background of primary care physician involvement in antiviral therapy management. So HIV treatment in Australia is more than 50% delivered by general practitioners. So that's an important sort of background. The answer is that it's incredibly variable in terms of general practitioner willingness to get involved and knowledge base and so forth. But we don't need even 50% of the general practitioners to get involved. We probably need 10 to 20% would be great. We've got 60,000 general practitioners in Australia. So even 10 or 15% of those getting involved. There's been a lot of education programs, a lot of mentorship. And I think what's happening is that once you get involved in treatment, I mean, there's not many areas of clinical medicine where you can cure a chronic disease fairly reliably. And of course they need education, of course they need sort of mentorship, but that opportunity to have such an input into that sort of area of clinical medicine, I think a lot of people are taking that on board and really wanting to get involved. And it's a great area of clinical medicine to be part of. And it's empowering. So I think as a specialist, we shouldn't hold on to that. We should help distribute that empowerment to other healthcare professionals.